Dr. Michael Bernard from Oshner Clinic. He's going to show us a few cases of Volta AF-Xplorer II integrated into NSiteX with HT Grid.
All right. Thank you very much, and thank everyone from Volta for having me here to show our experience with this very exciting technology. These are my disclosures. Before I get into this, many of us have our own version of a redo AFib ablation. I'm sure everyone has their own type of what they do. Mine, before this technology, is I would typically do a CTI line if they had not had one before. I would re-isolate pulmonary veins. I'm guilty of being a posterior wall isolationist. And then if they had preclinical flutters or atypical flutters, we would induce. And that was basically my practice for many years. I then saw this technology and have incorporated that into my workflow, and to show you a couple of cases. Our experience is roughly 40 cases, predominantly persistent, predominantly redos. I do have 2 paroxysmals today, and really they're probably paroxysmals bordering on persistent. They're both female patients, and so maybe my instincts were correct that the PVs were not everything. I'm an Insight user. I use GridX. That's my preferred mapping tool, and I use Tactiflex for my ablation. So our first case, a 7-year-old female that had a cryo PVI in 2015, had a redo PVI in 2018, also with a CTI line, and she started developing paroxysms of AFib, bordering on a persistent technical definition with recurrent atypical flutter and cardiomyopathy. So we brought her in for a case with Volta. Her CTI was blocked on the way in. And what you see on the top right, I like to make a voltage map of the left atrium just to get the lay of the land. And as this map concludes, what we'll realize that the right pulmonary veins remain isolated, the left pulmonary veins had reconnected, and like I would do prior to Volta, I like to isolate the left pulmonary veins. I did do posterior wall. And given that she had atypical flutter and AFib, we then went on to try to induce. And you see the map completing there. Right PV is isolated. It looks like on the roof we're reconnecting the left veins. So then we went in for an induction, and what I'm showing you in the top left is the Volta screen that you see. This is because I use grid. You'll see a grid. If you use Penarray or Octaray, you will see that catheter. Similar, I presume, with Sphere 9, you'll see that catheter shape. And when it's, watch it change color as we go. And when the color changes, that's the device recognizing temporal dispersion or investigating it. And then you'll see that. And we'll talk about that a little bit later. So again, it took a while to get our AFib going, but once we got it going, we started to map in AFib. And if you watch as we're moving the grid around, I know this is very high speed and hard to see these electrograms, but once we got AFib going, we had temporal dispersion. Right, watch the grid here. You see it turn red and those rings come out in the low left atrial septum. I know it's challenging with the voltage map overlaid. I'll show you that without that shortly. And here we come, watch we come back to the same area. What I really think is amazing is the reproducibility of this. So we come back to the same area shortly. And again, we didn't see any dispersion anywhere else, but here we are again, same area. We reproduced that high dispersion zone. So, and I just included this slide. What do you see when you're mapping an AFib? Well, the top left is relative organized atrial activity, and then your grid, your Volta screen would look like this. As you move on to the top right, you see it looks disorganized or dispersed, but in the center of those electrograms, see we temporally organize and back. It may investigate that area, but it may not produce any tag. So that's a sign you can move on. Here in the bottom left, this is an area that had enough temporal dispersion to register temporal dispersion, but it wasn't, I guess, high stability. And if you look at the bottom right, this is an area, this was actually the low left atrial septum that had temporal dispersion, high stability, which means a longer term, which was more consistent with a site of termination organization. So these are the kind of things you're looking for. At the top left, you can move on. Top right, you can move on. Bottom two, wait and hold until you let the software have its time to analyze the data. We've done right atrial maps in virtually every patient. This was no exception. We did map the RA and AFib. Again, our CTI was blocked from before. We did get some high dispersion tags in the high lateral right atrium in this case, and in a cluster in the lateral wall. We'll get back to that later. You see the grid turning red and those secondary rings coming in. So at this point, my thought was to focus on the low left atrial septum first, and then address these right atrial ones second, because there's going to be a hierarchy of these clusters, and I went to the highest cluster density, which was in the low left atrial septum. So again, the Volta screen is not active at this point. We're getting our tachycardia here, and the orange dots are high stability dispersion points, and the purple are the moderate dispersion points. The bottom right is our Pruka screen, and you can watch the rhythm. And here we are ablating on the septum. Notice those white dots are denotating where the right wacka was from our prior case. If you watch the bottom, ablate this area, we terminate the sinus rhythm in this cluster. And at this point, we elected to consolidate this area, and we ultimately joined these two zones together. And you have a decision: do you go anterior toward the mitral valve to get to that isolated zone, or back to the right wacka? And here I'm showing we're moving back toward the right wacka to join the wacka to this area. And I'm not going to show all of it, but we went ahead and completed that portion, and then we came back and remapped. This area was isolated. Now back to the right atrium. Here were our tags in the right atrium. I've just terminated AFib. I have these tags. I think they should probably go after them, but I thought that could be close to the sinus node. And we made I'm glad I checked, because when we did this, sure enough, these were right around the sinus node. Now, it could be, portion of the crista terminalis. Because this was her third case, before we ablated these, we actually did a pretty deep induction run to try to induce AFib, and we couldn't. And you can see this is a little bit better. There's our sinus node, and those orange tags are pretty close, so we elected not to ablate. I've only seen this 3 or 4 times where we have tags near the sinus node. Again, this is this lady's third case. We really want to be sure we covered everything, but we did leave these. We did not ablate these zones. Our second case, another female, 50-year-old paroxysmal patient, had a radiofrequency ablation 2 years prior. She was becoming a recurrent AFib, started becoming more of a persistent, developing some heart failure, kind of early persistent type of patient. We did it. She also had CTI flutter as well as recurrent fib, so we took care of the CTI on the way in. And this is her map in sinus rhythm, the left atrium, again trying to get a lay of the land of what we have. And what we discover is that you can see that remnants of a portion of the left wacka set, and we have recurrence of both right and left veins. Left veins on the ridge and on the right veins on the roof. So my plan with this was to re-isolate veins, posterior wall, and then induce. But as we were re-isolating the left superior vein, she spontaneously went into AFib. So we took the moment to go ahead and map while she's in AFib. And again, we watched the Volta page in the top left. It turns red, it's investigating. It gets deeper red, or the ring is red. It'll start laying tags down. We have temporal dispersion up on the appendage. So we have some dispersion here in the low posterior wall, RAPV. We then had dispersion, there it is again. We had dispersion in again, low left atrial septum again. And we had left superior vein appendage base roof connection temporal dispersion there. So our tags were at that junction, posterior wall and low left atrial septum. And then I went ahead, I'll go to the next one. Then we went ahead and mapped the right atrium. We did have some tags in the right atrium. Again, there are only 2 or 3 compared to what we had in the left atrium. Once we completed mapping the right atrium, we went back to the left atrium to go ahead and start our ablation. Again, you can watch I think we get to the roof of the right atrium. We got some high stability tags right in the mid-roof of the right atrium in this case. Right about there. You see those secondary rings coming in, showing us that we have some tags. With this, my plan was to re-isolate the pulmonary veins from the left superior roof, make a roof line over to the right, because that's where the reconnection was. There were some low posterior wall lesions, kind of outside where traditional posterior wall set would be, so I made a decision to make a low, scooped out posterior line to incorporate those, and then go to the left atrial septum. So, and we'll see what happens when we start ablating. Again, these are the high dispersion tags at the appendage base. We confirm that we re-isolated the left superior vein, and now as we come over to the roof line, the grids in the right RSPV. As we come over here, we then isolate the right veins, and then see the purple cluster in the posterior wall. As we come across here, again, kind of a lower scooped out posterior line, and watch here as we get to this junction. I know it's sped up, but it slows, organizes, and terminates AFib right in that purple cluster. The posterior wall is not isolated this time. So it wasn't where we got posterior wall isolation. It's when we went through that cluster. And so then we went ahead and finished off the posterior wall, did the low left atrial tags, and we did ablate those 2 areas in the right atrium. We did do an induction run post and did not stir up any tachycardia. So these are the same tools I was using before I had Volta. I'm doing a lot of the same things I did before. Yes, there is extra mapping. Yes, there is extra time spent. But for these people coming back for second or third times, I find this is a great tool for our patients to help keep them out of AFib. And I feel like I've done everything I possibly can to help them be arrhythmia free. So again, the seamless integration of what we do, I think it's a great tool, and very happy to share these cases.